Good morning. And I have to say, I have a lot of pause getting up in front of all of you people and giving a talk like this. I think I'm probably a little more nervous than I would be if I was speaking in front of the American Surgical because of all these close friends who I've known for so many years. So I was asked to talk about an event that brought Jeff and me together years and years ago. My initial connection with Jeff was that I happened to be in the right place at the right time, and I was one of the early academic adopters of laparoscopic cholecystectomy. I started at WashU, and literally within about 6 months, this whole lap chole thing blew up in everybody's faces. And I joined SAGES. I was told I should join SAGES, and this is when it was all flexible, but I did join. And I was asked to teach at the SAGES Learning Center in 1990, where Jeff was president. And I met him at that time, and here I am, a young guy just out of training, essentially, and Jeff welcomed me into the SAGES community and said he was thankful for me to come and help teach at this course. About that same time, the American College of Surgeons Program Committee called me and asked me to organize a postgraduate course at the 1990 Clinical Congress in San Francisco entitled Complications, Real and Potential, Laparoscopic Cholecystectomy 1. And I was blown away by this invitation from the college. In fact, though, I was not a member of the college yet. I was too young. And a couple of weeks later, they called me and said, oops, we made a mistake. You can't organize a course because you're not a fellow of the college yet. So they asked Jeff to organize this postgraduate course. And he was nice enough to ask me then to be a moderator and presenter at this meeting. And this is where maybe I gained a little bit of notoriety for the first time. So Jeff, that was really remarkable that you did that. Now, at that meeting back in 1990, I mean, we were talking about all of these things that subsequently probably didn't make a whole lot of difference, like access, getting into the abdomen. Do you do an open or a closed technique? What kind of a port do you use? And there were all these debates about what was best about that and all the problems you could run into sparing blood vessels or the bowel or the bladder or other things. And about port site hernias. So Jeff, in his usual way, took his time but thought about this for some time, and if you don't have to make incisions on the abdominal wall, you're not going to have these problems. And so he was one of the organizers of the first no-scar organization, Natural Orifice Surgery Consortium for Assessment and Research. Now, there's some rumors out there that the name for this organization arose after a few drinks, but I can't confirm or deny that rumor. And so if you eliminate external access, you're not going to have those access complications. And Jeff was a leader in natural orifice surgery, along with his group, with natural orifice transluminal endoscopic surgery, or NOTES, subsequently POEM, per-oral esophageal myotomy. So all of you non-physicians out there, you got to know that surgeons love to put acronyms on things. POP, per-oral pyloroplasty, and intramural surgery, a whole new area of surgery, has been led by Jeff and his group over this period of time, with more than 25 publications and clearly leaders in the world in this area. But going back to that meeting in 1990 at the American College of Surgeons meeting, the main things that we talked about were specific complications of the laparoscopic approach to the gallbladder, and that was particularly bile duct injuries that were starting to be reported around the country. Now, what, again, you non-physicians may not realize is this was a true revolution. In the average general surgeon's practice in the United States, about a third of their operations are removal of the gallbladder, which had been around for 100 years with an incision in the right upper quadrant. And it was thought to be a relatively minor operation, but patients were in the hospital for 4 or 5 days, and there were some complications that arose. And all of a sudden, this whole new thing came along where we were taking it out with these little tiny incisions. People were going home the next morning at that time. And there was a huge push from patients to have this done. I certainly remember a number of times in the pre-op holding area where one of the patients who was going to undergo an open cholecystectomy by somebody else heard that I was going to take out her gallbladder with a laparoscope, and they would cancel the operation to make an appointment to see me. This is what was happening at that time. And so that we had these lay press articles coming out, taking the ouch out of surgeries. And here's another one that was very telling. This is from the Wall Street Journal around that time, the keyhole technique. And so this was keyhole and belly button surgery and laser surgery and all of these things that were being said about it. But the major thing is what I circled here at the bottom. Doctors scramble to learn it. And I tell you, it was the wild, wild west out of there at this point in time. These are the number of brochures that came across my desk literally in the 1 month in October of 1990 of the courses that were out there to learn how to do laparoscopic cholecystectomy. And shame on us as a profession, we still haven't got it right. How do you retrain surgeons who are no longer residents to do something new? We don't do it well even today. We're getting better at it, but back then it was terrible. In fact, there were some courses that were taught in hotel rooms in Las Vegas where the surgeons would take out one rabbit's gallbladder, and they would have called the local press back home to come and report on the first lap chole they were going to do on a human the following week. It was really shameful what was going on. For those of you who can't see this, it's, aha, there's the old gallbladder. Dang it, Lois, would you knock off all this squirming around business? And sometimes it seemed like this is what was going on at that time. And Lee showed something like this with a laparoscopic cholecystectomy learning curve, the probability of bile duct injury on the y-axis and the experience. And you can see that early in a surgeon's experience, the risk of bile duct injury was really quite high, way higher than it had been for the open operation through 100 years. And the reality is when bile duct injuries occur, it can be a very morbid problem, resulting in deaths, resulting in liver transplants, et cetera. And so it was a huge problem. And this is the sort of thing now that the lay press was saying in certain areas as well, and tighter rules urged on new gallbladder surgery. The state of New York thought about instituting rules about who could and who could not do these operations. Subsequently, over many years, we at WashU came up with this whole critical view technique thing, but that was years in the future. So common bile duct injuries, Jeff was very involved in attempts to try and reduce the incidence of these. He taught at many of the lap chole courses. He was instrumental in SAGES at that time in initiating the concept of train the trainers. The thought was if we could get the people, the experts from the SAGES organization out there to really lead these training courses, we could teach it in a responsible manner to try and reduce the problems that were going on, to enhance the surgery, enhance the safety during this rapid uptake of laparoscopic surgery. And their group published many peer-reviewed articles on how to prevent and subsequently manage common bile duct injuries. So other lessons I have learned from Jeff through the years: surgical innovation should be driven by surgeons, not by others. We should be the ones doing this, and we should be reporting it and reporting it honestly as we go forward. Mentees are your legacy, and those of us in surgical education really truly understand that that's one of the most important things we can do for the profession. Don't take yourself too seriously. We've seen a few photos. I'm going to show a couple of more just to show the fact that we surgeons, even though sometimes we get up in front of people and pretend like we really know a lot, in fact, we don't have to take ourselves too seriously. And one of the things that I've tried to emphasize, one of the things that I learned early from Jeff, but what I've tried to emphasize with the people with whom I work and with my trainees, are that passion and fun need to be important aspects of a surgeon's life. If you love what you do, and if you share that with those around you, then you really are not working hard. You're enjoying what you do. Lee showed this, the original lap wrappers, and I'd like to show off the attire of Dr. Jeffrey Ponsky here in all of his glory. And I've continued this on even without Jeff at certain times. Don't take yourself too seriously. But the final lesson I'd say from Jeff is that friends and family, especially one's life partner, and I'm looking at you, Jackie, are the secret sauce for happiness and life balance. Not work-life balance, it's all life. We have to balance it. Jeff, you've taught me that very well. Thanks for all you've done.